Hi everyone, today we are revising the management of malaria and common pediatric emergencies in children. This is not intended to replace everything you have learned over the years. My aim is to help you organize that knowledge so that when you meet a critically ill child or when an examiner gives you an emergency scenario, you should be able to say exactly what happened first, what can wait, and how to explain your decision clearly. Keep these 5 verbs in mind throughout this class. First, recognize. Second, resuscitate. Third, treat. Fourth, reassess. And communicate. Pediatric emergencies are rarely lost because nobody knows the name of the disease. They are often lost because danger was recognized late, treatment was given in wrong order, the dose was not calculated correctly, or nobody checked whether the child responded or not. Let us therefore think like clinicians at the bedside, not merely like candidates reciting a textbook. And let us first clarify this before we continue talking about the clinical approach. By the end of this session, I want a practical change in the way you approach the sick child. Within seconds, you should be able to decide whether the child is stable or unstable. If unstable, you should begin life-saving care in the correct order while asking for help. You should also be able to prescribe by weight rather than from memory alone. A drug name without a dose, route, formulation, and schedule is not a prescription at all. Finally, you must reassess. If you give oxygen, fluid, glucose, blood, or anticonvulsants, what response are you expecting? And what will make you stop or escalate? That habit of linking every action to a measurable response is what makes emergency care safe. It is also what distinguishes a mature final year student from someone merely listing management points. So, with that practical standard in mind, let us define the outcomes of today's lecture. These are 4 learning outcomes for today. First, you should apply a rapid first look and the ABCDE approach to every acutely ill child in the emergency room, because you should distinguish uncomplicated malaria from severe malaria and recognize major emergencies that can mimic malaria or coexist with it, such as sepsis, meningitis, pneumonia, and other illnesses. Third, you should manage the common immediate threats, namely coma, seizure, hypoglycemia, severe anemia, shock, and respiratory failure. Fourth, you should write safe weight-based prescription and state what you will monitor. Finally, you should be able to present an emergency case clearly in your examination. As we proceed, we do not only ask what is the diagnosis, we should also ask what is killing this child now. A child with malaria may be dying from hypoglycemia, severe anemia, or respiratory failure. Treating the parasites alone is not therefore enough. Those outcomes determine the route we will take through the next hour of this lecture. We begin with Universal Emergency Framework, ABCDE. ABCDE is not simply a checklist to recite. It is an assessment and treatment cycle. With airway, ask whether air can pass. Listen for obstruction. Look for secretions or swelling. Position the child appropriately and suction only when needed. Look for secretions and suction when needed. With breathing, assess rate, effort, chest movement, air entry, oxygen saturation, and cyanosis. If breathing is inadequate, oxygen alone is not enough, the child may need bag and mask ventilation. Please provide it. With circulation, assess pulse, perfusion, capillary refill, blood pressure, urine output, and bleeding. With disability, assess AVPU or GCS, pupils, posture, seizure, and bedside glucose checking. With exposure, check temperature, rash, trauma, edema, dehydration, and the child's weight. You notice that all 5 arrows lead to reassessment. After every intervention is administered, make sure you return to ABCDE framework. Call for help early, attach monitor, and document the time and response at every stage. Do not postpone stabilization while trying to obtain a perfect history. The framework you are seeing here is useful only if we can organize the first 1 minute efficiently. Now, emergency management, I must tell you, is a team work. It's a team activity. As you assess, organize the environment, call for senior help, and move the child to an appropriate resuscitation space. Ask someone to attach pulse oximetry, and where indicated, ECG and blood pressure monitoring may be required. Obtain IV access promptly. If repeated IV access attempts are delaying life-saving treatment, use intraosseous access according to the protocol. Check bedside glucose early in any child with severe illness. This is very important. Altered level of consciousness, convulsions, or inability to feed are the things that you must pay attention to. Obtain an accurate weight whenever possible. If that is impossible in an immediate emergency, use an approved estimate and correct it as soon as the child can be weighed. Finally, document precisely. Record the medicine in milligrams and milliliters, the route, the time, and the observed response after administering the drug. In an examination, saying "I will resuscitate" is vague and is not enough. State what you will call, state who you will call rather, what you will monitor, how you will obtain access, and which reversible abnormality you will check immediately. Okay, with the emergency structure in place, let us now apply the malaria knowledge. Now, let us apply the emergency framework to treatment of malaria. Fever is just a starting point, you must note, not a diagnosis. Headache, chills, vomiting, poor feeding, weakness, and body pain occur in many other infections, just as it is in malaria. Clinical diagnosis alone has poor specificity and encourages unnecessary anti-malaria use, while bacterial sepsis, meningitis, pneumonia, and urinary infection may be missed. A positive malaria test also does not close the case. In an endemic setting like ours, parastemia may coexist with another serious illness. Therefore, if the clinical picture is not fully explained by malaria, just continue to look for the cause of the fever. The practical rule here is this: test before treating any suspected uncomplicated case of malaria. However, in a critically ill child with suspected malaria or severe malaria rather, take the parasitological sample promptly, but do not delay resuscitation or parenteral therapy while waiting for the result. This distinction, test before routine treatment, but never delay emergency treatment, is very important point that you must take notice of. Because symptoms overlap with many illnesses, the next steps that I'm going to take you through is a discipline diagnostic pathway. Let us walk through this algorithm from the top to the bottom. The child has fever or a history of fever. Before focusing on malaria, assess the ABCDE and look for danger signs. Then perform a parasitological test using an RDT, microscopy, or both, depending on the availability and clinical situation of the child. If the test is positive, there is no severe feature or no features of organ dysfunction, the child follows the uncomplicated malaria pathway and receives an appropriate oral ACT. If the test is negative, do not routinely give an anti-malaria simply because the child is febrile. Seek another cause and reconsider whether repeated or alternative testing is needed. The central red pathway overrides the others. Any serious feature or life-threatening feature or severe features or inability to take oral medications require immediate management as severe case of malaria when it is suspected. Remember also the sentence at the bottom of this slide that a positive result does not exclude sepsis, meningitis, pneumonia, or another coexisting illness. What this means is that you must always look for other causes of fever and other causes of all these organ dysfunctions, signs and tests. Now, let's talk about RDT and microscopy. And RDT and microscopy are complementary rather than identical. The main strength of RDT is speed, accessibility. It can bring parasitological confirmation to facility where high-quality microscopy is not immediately available. Its limitation depends on the antigen target, storage condition, product quality, and parasite density. An HRP2-based test may remain positive for weeks after effective treatment, so it may not distinguish a new infection from recently treated malaria. Microscopy can identify species, quantity or quantify parasite density and monitor parasitological response. However, its quality depends on the specimen preparation, the staining of the slide, equipment, and competence of the microscopist that is carrying out the procedure. Therefore, choose the test according to clinical questions, not according to your intuition and not according to what the book says. If you need rapid confirmation, an RDT may be appropriate. If you need species identification, the density quantification, and follow-up parasitemia, the best option is microscopy. And this is usually the case when you are managing a case of severe malaria. All right. Nevertheless, interpret any test without considering. Never interpret any test without considering the child's clinical condition. I meant to say. Now we understand the test. Let us decide who can safely be treated with oral medications. And this group of children are uncomplicated cases of malaria. They need oral medication, not parenteral. Uncomplicated simply means symptomatic parasitemia without any evidence of severe malaria, or vital organ dysfunction. That definition matters because the presence of even one severe feature changes the route of treatment, changes the urgency. It also changes the place of care and monitoring. In Nigeria, for instance, recommended quality assured ACT options include artemether lumefantrine, artesunate amodiaquine, and dihydroartemisinin piperacin, according to current national guideline and available formulation. Do not use oral artemisinin monotherapy because incomplete parasite clearance encourages recrudescence and parasite resistance. Before writing your prescription, obtain the current weight of the child. Explain the full schedule to the mother or caregiver. The importance of completing all doses is also critical. What to do if the child vomits is an important information the mother must be aware of, and the danger sign that requires immediate return to the hospital. An ACT prescription must name the specific combination, the strength, the number of tablets, or the volume per dose. The timing of all doses and the duration also must be well stated. So now we will make that treatment concrete by walking through the common ACT that is artemether lumefantrine schedule. Now this slide shows you the schedule for artemether lumefantrine. As you can see, you need to administer 6 doses over 3 days. This is the commonly used artemether lumefantrine, and that is 20 by 120 milligram tablet. In other words, 20 milligram of artemether and 120 milligram of lumefantrine in a single tablet. The key is the weight band. A child from 5 to less than 15 kilograms receives just 1 tablet per dose. 15 to less than 25 kilograms receives 2 tablets per dose. 25 to less than 35 kilograms receives 3 tablets per dose. And a patient weighing 35 kilograms or more receive 4 tablets per dose, which is also the adult dose. There are 6 doses. The first dose should be given at hour 0. The second is 8 hours later. Then morning and evening daily for the next 2 days, making 6 doses rather. Do not reduce this to the vague instruction twice daily for 3 days. No, this is not the correct way of writing prescription for ACT, because it can obscure the 8-hour second dose if you say twice daily only. That is not sufficient. Lumefantrine absorption improves with milk or food that contains fat, where this is available. It improves absorption and it makes the bioavailability of the drug better. Ask about vomiting. If a dose is vomited, follow the current product and the national guideline instruction, which states that you should repeat the dose after about 30 minutes. A correct schedule is only the beginning. The next thing I'm going to do is to ask what to do when recovery does not follow. When you give a drug and the child is not getting better, what should you do? When a child is not improving, do not automatically label that child's infection as resistant and prescribe another ACT. No. First, verify the treatment. Was the way correctly documented or used in the prescription? Was the formulation correct? Did the child caregiver understand the schedule? Were the doses retained, or was the child vomiting? Second, reassess severity and complication of the illness. A child who was initially uncomplicated may now have severe hypoglycemia or an anemia, shock, or another severe feature of malaria. Third, reconsider the diagnosis. Could this have been meningitis, pneumonia, sepsis, urinary tract infection, or another febrile illness? So, repeat the microscopy or reassess parasite density when clinically indicated, and then reevaluate the child altogether by examining the various systems to check whether there's a focus of infection. The lesson here is that treatment failure is a clinical problem requiring explanation, not merely a drug selection problem. If the child is deteriorating or unable to retain oral medication, escalate immediately to the severe disease pathway rather than repeating, changing oral medications. All right. In the next slide, I'm going to talk about how to move from failure to improve if a concern happens. So, in severe cases of malaria, we simply look out for vital organs dysfunction. Severe malaria is defined by vital organs dysfunction, not by how high the fever is. On the left are neurological and respiratory features that characterize severe malaria, and these include impaired consciousness or coma, repeated convulsions, prostration or inability to drink, repeated respiratory distress or acidosis, and severe anemia. On the right side of this slide, we have hypoglycemia, shock, acute kidney injury, or hemoglobinuria, abnormal bleeding, or other organs dysfunction, and parasitemia as a high risk markers of severe malaria. Do not wait for accumulated several features before you decide that this is severe malaria. One severe feature is enough to change management. The child requires urgent resuscitation, parenteral anti-malaria treatment, close monitoring, and management of complications. In an endemic area like ours, remember that parasitemia may be incidental. If a child with a positive test has neck stiffness, focal signs, purpura, or a septic appearance, continue to investigate and treat possible bacterial disease. Severe malaria and bacterial sepsis can coexist. This has been well documented. So once severe malaria is recognized, treatment and investigation must proceed at the same time, that is in parallel. This slide shows where severe malaria management should occur in parallel, not as a long sequence. First, you need to recognize severity, call for help, record the wave, and note the time. One team member stabilizes ABCDE, gives oxygen when indicated, obtain IV access, and check glucose and treat seizure accordingly. Another prepares and administers parenteral artesunate immediately. Do not wait for all investigations to return before you commence treatment. At the same time, collect the essential samples, blood smear, or RDT, full blood count, glucose level, electrolyte, and creatinine, cross-matching of blood, and blood culture when bacterial infection is suspected. Then support the complications, anemia, shock, AKI, and acidosis, and then observe the child continuously. The arrows converge on reassessment, as you can see, because treatment is dynamic. Monitoring of vital signs are important. Level of consciousness, glucose, urinary output, fluid balance and response, they all need to be monitored repeatedly during the admission. Severe malaria is not managed by artesunate alone. Survival depends heavily on the quality of supportive care the child has access to or receive. So, the time critical drugs in that parallel response is parenteral artesunate. So let us dose the child accurately and promptly so. Now, parenteral artesunate is the key drug for treatment of severe malaria cases. This is a dosing point that you must be exact about, as demonstrated on this slide. Children weighing less than 20 kilograms receives artesunate 3 milligrams per kg per dose. Children weighing 20 kilograms or more receive 2.4 milligrams per kg per dose. Give the dose at hour 0, 12 hours later, and 24 hours. Then once daily until oral tablet is tolerated. If the child is able to tolerate as soon as possible after 24 hours, then you change to oral ACT and give the full dose. Okay, why are we emphasizing the 20 kilogram threshold? This is because the common error is to give 2.4 milligram per kilogram to every child. In smaller children, that underdoses the recommended regimen. Parenteral injections are not the complete course of treatment for severe malaria. After at least 24 hours of parenteral therapy, and when the child can tolerate oral medicine, complete a full 3-day ACT, reconstitute and administer the injection exactly according to specific product instruction. In an examination as students, please note the calculation. You need to know how to calculate the dose and say it aloud and state the timing clearly as well. Accurate dosing is important, especially when malaria presents with coma or recurrent convulsions. In the case of cerebral malaria, okay, we require that pre-falciparum parasitemia be demonstrated, unarousable coma, and absence of any other explanation for the coma or loss of consciousness. The last part is crucial. Do not assume that every unconscious child with a positive malaria test has cerebral malaria. Please consider the post-ictal state case, hypoglycemia, meningitis, encephalitis, poisoning, trauma, and metabolic disorders. Management begins with physiology. Protect the airway, assess ventilation, position the unconscious child laterally and when appropriate. Check glucose immediately and treat prolonged seizure using the current protocol. Record the level of consciousness serially, and this is part of nursing care and very vital. As a doctor, you must also pay attention to it and ensure that proper documentation is made concerning all these supportive care. Never give oral fluid or oral medication to an unconscious child. That creates a major aspiration risk. If meningitis or sepsis cannot be excluded, obtain appropriate culture where feasible and give empiric antibiotics promptly. A lumbar puncture must never delay treatment in an unstable child. Please, having recognized cerebral malaria, we must now manage it and the accompanying organ complication. And this takes us to severe malaria complication and the safe thing to do. This table contrasts safe actions with common dangerous shortcuts that people often resort to. For hypoglycemia, use an appropriately diluted pediatric glucose preparation, okay, which is 10% glucose. Then recheck and prevent recurrence. Do not produce a routine 50% dextrose bolus in a child, but rather make sure it is diluted up to 10% glucose. For severe anemia, use the appropriate weight-based blood products and monitor closely. Furosemide is not automatically required for every transfusion. For shock, identify the likely cause and give cautiously what is missing, whether fluid or blood. Reassess treatment afterward. Severe malaria is not an indication for blind large volume or boluses. No. So treat according to what the child requires. For AKI, maintain accurate fluid balance, check electrolytes and renal function, adjust medicine and refer early as possible. Call the attention of the nephrologist to this. Avoid the old blanket fluid plus fluorescent challenge that we often used to talk about. For pulmonary edema, support oxygenation, restrict unnecessary fluid, and escalate. Okay, the governing principle is this, and it's simple. Fluid, blood, glucose, and diuretics are powerful drugs. Prescribe them for an indication and monitor the effect, and do not just prescribe them arbitrarily. So, safe complication management depends on repeated measurements. So, monitoring becomes the next thing we are going to discuss. Monitoring is not clerical work at all. It is part of treatment. Initially, assess airway, respiratory effort, oxygen saturation, pulse perfusion, blood pressure, temperature, and level of consciousness as frequently as the severity requires. A routine 6-hour interval is not appropriate for an unstable child. Repeat blood glucose because hypoglycemia may occur. Monitor hemoglobin, electrolyte, creatinine, and parasitemia according to the presentation and response. Maintain strict input and output record. Document every medication and inspect intravenous or intraosseous sites frequently. Before discharging the child should be clinically improving, feeding, tolerating oral medications, and do not have complication of the severe malaria, or if any had occurred, must have been properly addressed. The caregiver must understand complications or completion of therapy is important, and also the danger sign that may arise during follow-up. After parenteral attest unit, remain alert for delay hemolysis. Follow the local surveillance policy as may be stated in the emergency room protocol. Good clinicians do not merely initiate treatment, they prove that it is working. Therefore, make sure the child is monitored, and every child in the emergency room deserves monitoring. So we now carry the same ABCDE and assessment logic into respiratory emergency as we go to the next slide. Now we move from malaria to respiratory emergencies, but our ABCDE logic remains the same. Respiratory distress include tachypnea, recession, chest recession, nasal flaring, grunting, wheeze, or stridor. The child is working hard to maintain gas exchange in all of these cases. Impending respiratory failure may look deceptively quieter. The child becomes exhausted, respiratory effort decreases, air entry becomes poor, and the chest may become silent in such a case. Cyanosis, altered consciousness, bradycardia, apnea, or gasping are late and dangerous signs of respiratory failure. Therefore, a reduction in noise does not always mean improvement of the condition. So, be careful. Impending respiratory failure may look deceptively quieter, as I said earlier on. All right? Your first actions is to position the child well, open the airway, measure oxygen saturation, give oxygen when hypoxic and severely distressed, and support inadequate breathing with bag and mask ventilation. Call for skilled airway help early, but that is, invite the respirologist or pulmonologist to attend to the child as quickly as possible. Always treat the cause, but do not wait for the final diagnosis before supporting oxygenation and ventilation. After recognizing respiratory failure, careful auscultation help us to localize the cause of this emergency. Breath sounds can help you localize the problem. Stridor suggests upper airway obstruction. Keep the child calm, provide oxygen as indicated, and prepare an airway plan while treating causes. such as croup, foreign body, or anaphylaxis. Wheeze suggests lower respiratory tract narrowing, pointing towards asthma. Viral wheeze or anaphylaxis. Crackles or bronchial breathing suggests parenchymal disease such as pneumonia, although pulmonary edema must also be considered. Unequal airway entries raises concern about a foreign body, pleural effusion, or pneumothorax. A tension pneumothorax is treated clinically and should not wait for imaging. Okay, so you must be able to detect this early through a thorough examination. Grunting with marked pallor may be systemic rather than primary pulmonary condition. Severe anemia, acidosis, or sepsis can produce respiratory distress. Okay, the lesson is to interpret the sound together with perfusion, pallor, fever, cardiac signs, and overall ABCDE assessment. Let us apply those sounds pattern first to acute asthma as we look through this slide. In acute asthma, assess what the child can say or drink, the level of alertness, respiratory rate, accessory muscle use, air entry, oxygen saturation, and peak flow, okay, if age and condition permits. A child who cannot speak is exhausted, has poor air entry, or a silent chest, has a life-threatening attack. Give repeated inhaled salbutamol, a pressurized meter dose inhaler with a spacer device is effective for many mild or moderate attacks. Severe or life-threatening attacks may require oxygen-driven nebulization according to the local protocol. Give systemic corticosteroid early in moderate or severe exacerbation of asthma, and then add inhaled ipratropium in the severe attack of asthma. If the response is poor, escalate early for intravenous magnesium and critical care support according to protocol. Do not sedate any acutely breathless child. After each treatment cycle, make sure you recheck air entry, work of breathing, oxygenation, and then the mental health states of the child. So we then contrast asthma with pneumonia, where infections and oxygenation dominate management in this lecture. For severe pneumonia, you must look beyond cough and fever. Ask whether the child is hypoxemic, has severe respiratory distress, or whether the child cannot drink, or has altered level of consciousness or shock. Look for complications such as effusion, empyema, thoracis, pneumothorax. Okay, support oxygenation and ventilation first. Obtain culture if this can be done without delay in treatment, and start locally recommended parenteral antibiotics promptly as soon as you can. Okay, reassess response and consider complications if the child fails to improve. Also, keep the differential diagnosis open. Malaria, severe anemia, heart failure, asthma, and inhaled foreign body may present with respiratory distress. A positive malaria test should not stop you from diagnosing pneumonia. Okay, crackles in a child receiving fluid should prompt consideration for fluid overload or cardiac disease. Again, physiology and repeated examination guide safe management in cases of emergency in children. So from breathing problem, we move to another critical emergency, which is convulsive status epilepticus. A convulsion lasting 5 minutes or recurring without recovery is treated as convulsive status epilepticus. Start timing. Perform ABCDE framework. Support oxygenation when needed. Check bedside glucose. Protect the child from injury and prepare suction and ventilation equipment. Okay, give the approved first-line benzodiazepine using a weight-based intravenous, buccal, intranasal, or rectal route according to the current hospital protocol. Watch breathing continuously. If the seizure persists, repeat once if the protocol allows it, but do not keep giving benzodiazepine indefinitely. Prepare the approved second-line anti-seizure medication and be ready to support ventilation. Do not insert a spoon, finger, or other object into the mouth. Do not restrain the child forcefully. Once the seizure stops, reassess ABCDE because the medicine, the seizure, and the underlying disease may also compromise breathing and level of consciousness. Stopping the seizure is not the end point of the treatment of this kind of condition. We must then search systematically for what caused that situation. The mnemonic head fit helps organize the differential diagnosis after immediate stabilization in the case of convulsive status epilepticus. H reminds us of hypoglycemia and hypoxia. E stands for electrolytes and other metabolic disturbances. A is acute CNS infection or raised intracranial pressure. D is drug, toxin, or withdrawal. F is fever and malaria. I is injury or intracranial bleeding. T is known epilepsy, non-adherence, or treatment failure. After the seizure, document its duration, pattern, medicine, and response. Ask about fever, trauma, ingestion, previous seizure, adherence to drugs, development, and immunization. All this must be documented. Examine the child for meningism, focal neurological signs, raised intracranial pressure, presence of rash, injury, and the source of fever. Choose investigations according to the context. Lumbar puncture is considered only after stabilizing the child, when no contraindications exist. Okay, if meningitis or encephalitis is suspected in an unstable child, start treatment promptly. Do not wait for lumbar puncture before you start the treatment. In this lecture, the next major physiological threat is shock, and that is what we are going to be discussing now. Shock means inadequate tissue perfusion. Look for tachycardia, all right? Weak pulse, prolonged capillary refill, temperature gradient, alter mental state, and reduce routine output. Hypotension is a late sign in children, so don't wait for that to happen. Begin ABCDE, and then give oxygen when indicated. Obtain intravenous access, check glucose, and then send essential tests that need to be done as the case may be. Then ask what type of shock is this? Is there hemorrhage or severe anemia? If so, control bleeding and arrange the appropriate blood rather than blindly loading the child with crystalloid. Is fluid responsive, hypovolemic, or distributive shock likely? If so, give a small isotonic aliquot according to protocol and reassess pulse, capillary refill, blood pressure, lungs, liver, and urine. If there is no improvement at all or sign of overload appears, stop and rethink the cause or your diagnosis. Escalate to vasoactive or critical care pathway. Severe malaria, severe malnutrition, and cardiac disease requires special caution when dealing with making decisions with fluid. And the reasons are very clear. Overloading may compromise the life of the child, so be careful. When infection is a possible driver of shock, the same urgency extends to sepsis care. And that is what we are going to be discussing right away. In suspected sepsis, call for help, obtain IV access, check glucose, and send blood culture and organ function tests where available. Cultures are useful, but they must not delay the treatment or administration of local recommended broad spectrum antibiotics. Support oxygenation and ventilation as required. If shock appears fluid responsive, use cautious isotonic aliquot with reassessment after each one. In settings without intensive care support, indiscriminate rapid boluses can be very harmful. If the shock persists, escalate early to the approved vasoactive and critical pathway. Finally, find and control the source. Consider meningitis, pneumonia, urinary tract infection, intra-abdominal infection, skin, bone and joint infection, and device-related infection. Malaria may coexist with bacterial sepsis. Please note, sepsis is not the end of diagnostic thinking. It is a time-critical syndrome that requires immediate treatment while the source is being identified. Another common route to circulatory compromise is dehydration, but its fluid plan begins with classification. So we must first classify before we begin to rush in fluid to any child that is dehydrated. For dehydration, you need to classify severity clinically. A child with some dehydration is often restless or irritable, has sunken eye, drink eagerly, and has a skin pinch that returns slowly. A child with severe dehydration may be lethargic or unconscious, have sunken eyes, drink poorly or unable to drink, and have a skin pinch that returns very slowly. Some dehydration is generally managed with oral radiation solution based plan. Okay, so continue breastfeeding and feeding. Replacement of ongoing losses and reassessment. Severe dehydration, on the other hand, requires urgent intravenous fluid or rehydration using the current pediatric or WHO plan with frequent review. Okay, this classification is not mechanical. Shock, severe malnutrition, heart disease, and severe malaria alter fluid decision, and this you must pay attention to anytime you encounter a child with dehydration. You need to ask yourself, am I dealing with a case of shock, or is it a case of, is the child malnourished, so that you can be careful with the fluid. Heart disease or heart failure, or if it's a case of severe malaria, you don't want to give too much. Antibiotics are not routine for watery diarrhea, okay, acute watery diarrhea rather. Use them only when specific indications such as dysentery, cholera, or an identified extraintestinal infection is found. Okay, continue zinc therapy according to current national guideline. So let us now consider two rapidly reversible killer that may accompany any of these presentations. Hypoglycemia is one of them, and should be suspected in any child with altered level of consciousness. Seizures, severe infections, malnutrition, prolonged fasting, liver disease, or insulin exposure. Check immediately, okay, and use 10% glucose at 5 minutes per kg intravenously, okay, where applicable. Please recheck promptly and provide ongoing glucose or feeding to prevent rebound hypoglycemia and recurrence of such. Avoid routine use of undiluted 50% dextrose in children because of dosing error and tissue injury that is likely to happen. For severe anemia, look for marked pallor and tachycardia, gallop rhythm, hepatomegaly rather, respiratory distress, shock, and altered consciousness. Send a full blood count and blood film. Group and cross-match blood. Test directed at identifying the causes are also important for to ask for at this point. Transfuse the child according to the approved emergency room protocol. The volume and the rate, and then monitor the child closely for reaction and fluid overload. Do not give furosemide automatically with every transfusion. Use it only for a specific indication. So now from hypoglycemia and anemia, we move to an emergency in which one drug must come first, which is anaphylaxis. Recognize anaphylaxis as a sudden airway, breathing, or circulation problem, usually accompanied by skin or mucosal features such after exposure to a trigger. Skin sign may be absent, so do not wait for skin rash eruption when airway obstruction or shock is already developing. Call for help. Remove the trigger if possible, and position the child appropriately, generally flat with legs elevated unless breathing requires another position. Give intramuscular adrenaline into the anterolateral aspect of the thigh using the current age or weight-based protocol. Provide oxygen. Monitor intravenous fluid, and get intravenous access and administer fluid rather. Repeat adrenaline as the protocol directs and give fluid if shock is present. Observe for recurrence or a biphasic reaction. Antihistamine and corticosteroids may be supporting in their roles, but they do not replace the intramuscular adrenaline, which should come first. In examination, the first drug you mention should be intramuscular adrenaline, not hydrocortisone or chlorpheniramine. The next metabolic emergency that also demand protocol-based fluid and drug decision is diabetic ketoacidosis. Suspect diabetic ketoacidosis in a child with polyuria, polydipsia, weight loss, dehydration, vomiting, abdominal pain, ketotic breathing, small breathing, or altered level of consciousness. Confirm glucose, blood or urine ketone, venous pH or bicarbonate and electrolytes. Monitor ECG and neurologic status. Management must follow a pediatric DKA protocol, which I believe is available in our hospital. Begin carefully with isotonic fluid replacement, then start an insulin infusion at the specified time and rate based on the protocol. Never give an insulin bolus. Potassium replacement depends on serum level of potassium, urine output, and ECG. Follow corrected sodium and other biochemical trends as may be required. Watch closely for cerebral injury, headache, slowing pulse, rising blood pressure, reduced level of consciousness, cranial nerve abnormality, or desaturation. Treat urgently using cerebral injury pathway and critical care help. Do not delay treatment while waiting for brain imaging. Not at all. It's not an indication immediately until you have stabilized the child. We will finish the individual emergencies with poisoning in the next slide, where protection and supportive care come before the antidote. In poisoning, first protect yourself, the team, and the child from ongoing exposure. Perform ABCDE framework before trying to identify every detail of the toxin. Check glucose and obtain an ECG when the substance or presentation makes this relevant. Then establish the agent, dose, time, route of exposure, and the possible co-ingestion or ingestants. Ask the caregiver to bring the container or label safely, but never expose staff to contaminated materials. Okay, contact poison information or clinical toxicology centers available in your center. Most poisoning management is excellently supported by supportive care. Rather, use a specific antidote only when indication is clear. Do not induce vomiting in any case of poisoning. Activated charcoal is not a routine care in all cases. It is considered only for suitable ingestions within an appropriate time window and when the airway is protected. Okay, a drowsy child should not be forced to drink anything at all. Continue monitoring because some toxins have delayed effect. Okay, so having said this, we will now integrate the principles that we have been talking about in an examination style and integrated with severe malaria. Now, let us integrate the principles. This 3-year-old weighs 12 kilograms, has fever, repeated convulsion, marked pallor, deep breathing, prolonged capillary refill, and hypoglycemia with a positive malaria RDT. My opening statement will be, this is a critically ill child with neurological, respiratory, and circulatory compromise, hypoglycemia, probable severe malaria, possible severe anemia, and possible sepsis. I will call for help and begin ABCDE of resuscitation. I will support oxygenation and ventilation as indicated. Obtain an intravenous access and treat hypoglycemia and check it. If the child is still convulsing at 5 minutes, I will treat according to the status protocol and monitor breathing. Okay, I will take a smear full blood count, cross-match blood, obtain blood for electrolytes, creatinine, and blood culture as indicated without delaying treatment. Because the child weighs less than 20 kilograms, artesunate will be administered at 3 milligram per kilogram, and then this means I will administer 36 milligram per dose. I will assess anemia, heart failure, for heart failure as well, and then use a cautious shock plan and consider giving antibiotics if I found or suspect a focus of infection. Okay, with the integrated approach established in this lecture, let us expose ourselves to two common examination bedside traps that students may often fall into. Okay, case A is an 8-year-old with asthma who cannot complete sentences, has an oxygen saturation of 88%, marked recession, and very poor entry. The trap is to interpret reduced wheeze as improvement. This is a life-threatening asthma with impending respiratory failure. Okay, so what you need to do is to call for help, give oxygen, repeated and continuous bronchodilator treatment according to protocol, add ipratropium and systemic steroid, obtain access and escalate as early as possible for magnesium and ventilatory support. So do not sedate the child. Case B is a 2-year-old child with diarrhea, lethargy, and weak pulses, but also has hepatomegaly and basal crepitations. The trap is to give an automatic rapid fluid in this case, but it should not be so. These signs suggest possible cardiac dysfunction or fluid overload. So stabilize the child following the ABCDE framework. Check for glucose, obtain intravenous access, and then call for senior help. And use cautious directed resuscitation with repeated lungs examination, liver and perfusion assessment. Okay, avoiding those traps require prescription that remains accurate all the way to administration. So we talk about prescribing in pediatric emergency. So and how to calculate. A safe pediatric calculation does not end at milligram per kg. For the 12-year-old child that we discussed earlier, artesunate is 3 milligram per kilogram body weight. So giving 36 milligram per dose. For a 25 kilogram child, use 2.4 milligram per kg. Okay, giving 60 milligram per dose. Then confirm the formulation, calculate the volume to draw up, state the route and timing in your documentation. Check the maximum dose and then document that the child should be monitored and how this should be done. For 10% glucose at 5 mils per kg in a 12-year-old child, the volume is 60 milliliter, followed by prompt glucose rechecking. For an 18 kilogram child receiving artemether lumefantrine, the weight band requires 2 of 20 by 120 milligram tablet per dose for 6 doses. Say the calculation loudly in an exam and mention milligram, formulation, milliliter or tablets, then the route, the timing, the maximum, and then the monitoring of the child. This prevents hidden prescribing error in any situation. So the calculation discipline helps us recognize the broader errors that make people to lose marks or harm children in practice. These are shortcuts we must deliberately avoid. Okay, do not equate every fever to malaria. Test, look for coexisting disease. Do not wait for a laboratory result before treating suspected severe malaria cases. Take the sample and then treat immediately. Do not use 2.4 milligram per kg of artesunate for every child. Those under 20 kilogram requires 3 milligram per kilogram. Do not give a large fluid bolus automatically for every child with shock. Diagnose the likely cause and reassess after cautious treatment. Okay, do not repeat sedative blindly. Monitor ventilation and follow a timed seizure protocol. Finally, ACT for 3 days. That's what is prescribed. It's not a complete prescription. Okay, but you must write it clearly how to administer it: 0 hour, 12 hour, then morning and evening, not just blindly twice daily. Specify the drug combination, formulation, strength, number of tablets, or volume per dose. All 6 administration times must be clearly stated. The route, and then counsel the mother or caregiver. Okay, please pay attention to all these details. Finally, let us practice how to communicate the whole emergency as we in just 60 seconds. Okay, how do you explain, how do you talk to a colleague about the child that is in the emergency room? When presenting an emergency case, speak in a fixed order. Start with the child's age, weight, and key complaints. State whether the child is stable or unstable. Give the physiological evidence. For example, the child is unstable because there is respiratory failure, poor perfusion, and altered level of consciousness. Then state the leading diagnosis and the important alternatives or coexisting conditions. Okay, describe the ABCDE actions that you have already taken. Give definitive treatment, and then with exact dose, the route, the timing, and finally state what you will monitor and the criterion for escalation to whoever you are talking to about the child. So a concise model is: this is a 12 kilogram child with severe anemia, complicated with hypoglycemia and probable severe anemia. If I have called for help, supported ABCDE, treated glucose and started artesunate at 30 milligram, and I am arranging cross-matched blood, considering antibiotics and monitoring level of consciousness, glucose, perfusion, respiration, and urinary output. That is an organized, measurable, and clinically credible way of making presentation. From the presentation structure, we can then still see that there are 7 rules worth carrying into the ward or examination hall as you prepare for your exam. Let us consolidate the session into these 7 rules. First, airway, breathing, circulation, and glucose cannot wait for a complete diagnosis. Second principle: a positive malaria test does not end diagnostic thinking, so consider other possibility. Third, severe malaria require parenteral artesunate plus meticulous supportive care and monitoring. Fourth, artesunate dose changes at 20 kilogram, 3 milligram per kg below 20 kilogram, 2.4 milligram per kg at or above 20 kilogram. Fifth, fluid, oxygen, glucose, blood, and sedative are drugs, so prescribe them for as indicated, not just anytime you feel like. Titrate them and reassess when you are giving such therapeutic measure. Sixth, every intervention needs a response target and a stop or escalation rule. Seventh, when the child is unstable, always call for senior help early, and say that clearly anytime you are expected to. If you remember these rules, you will avoid many of the common errors that harm children and cost candidates in the exam. Those 7 rules bring us to the single sequence that unify the entire. Now return to this sequence with which we began. Okay, recognize the child is unstable, resuscitate physiologic threats in ABCD order, give definitive treatment, including the correct weight-based dose. The key message is that the child's physiology tells you what must happen first. The disease label guides definitive treatment. Okay, but airway obstruction, respiratory failure, shock, hypoglycemia, and prolonged convulsion and demands immediate action. So as you prepare for your examination, practice speaking in this order. When you see a child on the ward, practice it silently in your mind. Ask yourself, is the child stable? What is the immediate threat? What have I done? What response do I expect? When will I escalate? Thank you very much, everyone. So I welcome question at this time.